Welcome back to Chapter 10. This is Part 2, Nursing Care of Patients with Pain. Opioid antagonists. Naloxone or Narcan is a pure opioid antagonist that reverses or antagonizes the effect of opioids. It is often used in emergency departments for treating the effects of opioid overdose, such as sedation and respiratory depression. Caution must be used when giving naloxone to a patient who is receiving opioids for pain control. If too much naloxone is given too fast, it can not only reverse the unwanted effects, such as respiratory depression and sedation, but the pain may return as well. Some antagonists are shorter acting than the opioid that is being used. If the antagonist is given because of respiratory depression, the dose may need to be repeated because its effect may wear off before the opioid wears off. Be safe. Although respiratory depression is not a common side effect, it is a life-threatening one, and a respiratory rate should be monitored, especially when beginning opioid use or with dose increases. Always check the respiratory rate before administering an opioid and report any respiratory rate that is lower than 12 per minute or lower than normal for that patient. An additional sign of opioid overdose is pinpoint, very small pupils. Some analgesics are classified as combined agonists and antagonists or partial agonists. These drugs bind with some opioid receptors and block others. The most commonly used drugs in this class are butorphanol, also called Stadol, nalbuphine, also called Nubain, and buprenorphine, also called Buprenex. How does this information translate into nursing practice? Consider, for example, a patient who receives sustained release morphine every 12 hours to control metastatic bone pain, but the patient develops breakthrough pain between doses. You observe that butorphanol has been ordered for pain by another HCP and administer it. The butorphanol will antagonize or counteract some of the effects of the morphine, and the patient may experience acute pain. It is important to be informed about the actions of all drugs that are administered and to be aware of possible drug interactions that can interfere with patient care. Analgesic adjuvants. Adjuvants are classes of medications that are given in addition to other medications. Analgesic adjuvants can potentiate the effects of opioids or non-opioids, have analgesic activity themselves, or counteract the unwanted effects of other analgesics. Tramadol is an example of a commonly used adjuvant analgesic that acts very similar to an opioid. Some adjuvants are called off-label medications because they are being used in a way not specifically approved by the FDA. That is, they were not initially developed to treat pain. Adjuvants may have pain relieving properties for certain conditions. Although the use of adjuvants is common, nurses must be mindful of the side effects of these medications which often affect the central nervous system. Examples of adjuvants are corticosteroids, benzodiazepines, antidepressants, and anticonvulsants. See Table 10.1. Balanced approach to analgesia. A balanced analgesia approach should be used, combining analgesics and adjuvants from different classes to minimize the adverse effects of opioids such as nausea and vomiting or sedation while maximizing pain relief. For example, an opioid and a non-opioid given together can provide pain relief with an overall lower dose of each medication than if it was given alone. Because these drugs have different mechanisms of action and different adverse effects, it is possible to safely use them together. If doses can be reduced in this manner, additional sedating medications such as antiemetics and antihistamines to treat side effects may not be needed. Scheduling options. Analgesics of any kind can be administered either as needed or on a scheduled basis. Intermittent, unpredictable pain may be best treated with as needed doses. Pain that is predictable can be more effectively treated or prevented with scheduled doses of medication. Around the clock dosing is an effective way to schedule doses evenly over a 24-hour period to prevent pain from becoming unbearable. It is important to use around the clock dosing after surgery or trauma with chronic pain or in any other circumstance in which preventing pain will allow the patient to participate in daily or recovery activities. Patient-controlled analgesia. Patient-controlled analgesia, PCA, involves an opioid on an IV controller. The patient has a button on a cord that can be pushed to receive a dose of IV medication. The registered nurse, RN, programs the pump to the dose and dosing interval ordered by the HCP. A lockout mechanism prevents the patient from receiving the medication more often than ordered. PCA is an excellent option after surgery because it gives the patient some control over pain management. Teach the patient and family that only the patient should push the button, never the nurse or a family member. If the patient is too sedated to push the button, a dose of opioid is not likely needed and could even be dangerous. Critical thinking. Mrs. Jackson had abdominal surgery 2 days ago. She has been receiving morphine via an intravenous patient-controlled analgesia pump at an average of 2.5 milligrams per hour for the past 6 hours. She rates her pain at 3 on a scale of 0 to 10. She is to be discharged today. Her healthcare provider has ordered codeine 30 milligrams with acetaminophen, Tylenol with codeine number 3, 1 or 2 tablets every 4 hours as needed for pain at home. Number 1, will Miss Jackson be comfortable at home? Why or why not? Check the equa-analgesic chart, and the suggested answers are at the end of the chapter, so we're going to jump right there. Okay, this is on page 140 of the book. 1, using an equa-analgesic conversion, we can determine whether Miss Jackson is likely to have good pain relief based on her requirement with the patient-controlled analgesia pump. Her current pain level of 3 shows that the morphine has been effective. Remember that the PCA pump keeps a history of what the patient uses, which is the best indicator of what the patient needs. Ms. Jackson has used 15 milligrams of morphine during the past 6 hours. An equal analgesic dose of codeine, 30 milligrams, with acetaminophen, Tylenol with codeine number 3, would be almost 200 milligrams of codeine, but only 30 to 60 milligrams has been ordered. In addition, if Ms. Jackson takes enough Tylenol with codeine number 3 to get 200 milligrams of codeine, she will receive a dangerous dose of both the codeine and the acetaminophen. The HCP needs to be contacted for different analgesic orders. Okay, this is the bottom of page 129. Other interventions. Other pain treatments include topical local anesthetics, such as lidocaine/prilocaine cream, EMLA, which decrease the pain of procedures such as venipuncture and lumbar puncture. A lidocaine patch may be effective for patients with post shingles or other nerve pain. In patients with osteoporosis, drugs that promote calcium uptake by the bones can aid in pain relief. These may include hormonal agents and medications that decrease calcium reabsorption from bone. Placebos. The use of placebos involves the administration of an inactive substitute, such as normal saline, in place of an active medication. In the past, placebos were sometimes given in an attempt to determine whether a patient's pain was quote unquote real. This is unethical and inappropriate unless the patient has given written consent. The use of placebos is a denial of the patient's report of pain. If a placebo is ordered for a patient, discuss concerns with the HCP and nurse supervisor. Placebos are only to be used in drug studies or clinical trials to compare a new drug with an inactive substance. In this situation, patients are informed that they may be receiving a placebo. Routes for medication administration. Analgesics can be administered by almost any route. The oral route is desired in most instances because it is easy and painless for the patient and can be used at home. Table 10.3, see Table 10.3 for a comparison of the various routes. Non-pharmacological therapies. Non-pharmacological treatments are usually classified as either cognitive behavioral interventions or physical agents. The goals of these two groups of treatments differ. Cognitive behavioral interventions can help patients understand and cope with pain and take an active part in its assessment and control. The goals of physical agents may include providing comfort, correcting physical dysfunction, or altering psychological responses. Non-pharmacological therapies should be used in conjunction with drug therapies. They are not expected to relieve pain on their own. Table 10.3, routes for analgesic administration. Oral, the preferred route in most cases. Advantages are convenient, less expensive than other forms, immediate and controlled release forms are available. Disadvantage would be slower onset than IV form, nursing considerations. It can provide consistent blood levels when given around the clock, Controlled release form recommended for long-term use in chronic pain. Rectal may be used to provide local or systemic pain relief, can be used when patient cannot take oral medication. It may be difficult for the patient or family to self-administer. Some oral preparations can be given rectally. Place in empty gel cap for ease of use. Check with healthcare provider or pharmacist. Transdermal patch is used for chronic pain and it's easy to apply. It delivers pain relief for several days without a patch change. It may take up to 3 days before maximum drug level reached. Delay in excreting once removed. Patient must be closely monitored. Alternative routes may be needed when starting and stopping therapy. It may be less effective in smokers and very thin people. Absorption may be erratic. Absorption may be increased with fever. Avoid heat application over patch. Avoid touching medication when applying patch. Keep used patches away from pets and children. Intramuscular acute pain. Rapid pain relief, although slower than IV, painful administration and inconsistent absorption. Use only if other routes cannot be used. IV is the preferred route for postoperative and chronic cancer pain in patients who cannot tolerate the oral route. It provides rapid pain relief and continuous infusion to achieve a steady drug level. It's difficult to use in home healthcare setting and requires training and special equipment. Follow drug manufacturer's instruction for administration. Patient-controlled IV allows patients some control over administration schedule. The patient pushes a button to administer a dose of opioid. Requires special training. Pump must be programmed correctly. An hourly limit and lockout interval are programmed into the pump to keep the patient from receiving too much drug. Caution the patient and family that only the patient should push the button. Subcutaneous may be used if IV route is problematic. Can deliver effective pain relief. Some opioids may be given as a continuous infusion. Injection may be painful, and it may be effective for treatment of chronic cancer pain. Intraspinal, such as the epidural or subarachnoid, catheter into the epidural or subarachnoid space used for traumatic injuries or chronic pain unrelieved by other methods. May also be used for orthopedic, chest, and abdominal surgical procedures. May be able to control pain with lower doses of opioid because relief is delivered closer to the site of pain. Fewer systemic side effects. Requires single or continuous injection in back. May be associated with intense itching. Motor function must be assessed, especially when local anesthetic is used. Steroids may be given with opioid to reduce pain by treating inflammation. Local anesthetic may be paired with opioid to enhance pain relief. Avoid the use of anticoagulant and antiplatelet agents, including aspirin, because of the risk of epidural hematoma. Cognitive behavioral interventions. Page 131. Cognitive behavioral interventions include educational information, relaxation exercises, guided imagery, distraction, for example, music, television, and biofeedback. These treatments require extra time for detailed instruction and demonstration. The use of these modalities must be acceptable to the patient to be useful. Educating patients about what to expect and how they can participate in their own care has been shown to decrease patients' reports of postoperative pain and analgesic use. Relaxation can be accomplished through a variety of methods. The patient may prefer a scripted relaxation exercise that can be practiced and used the same way each time, or simply the use of a favorite piece of music that allows a state of muscle relaxation and freedom from anxiety. Guided imagery uses the patient's imagination to take the patient away from the pain to a favorite place, such as a beach in Tahiti. The success of guided imagery does not mean that the pain is in any way imaginary. See Chapter 5 for more information on relaxation and imagery. As noted earlier, distraction is commonly used by patients to focus their attention on something other than the pain. They may watch a favorite television program or laugh with visitors when they are in pain. When the program is over or the visitors leave, the patient may focus on the pain again and ask for a dose of pain medication. Biofeedback is sometimes used in chronic pain programs to teach patients how to train their bodies to respond to different signals. Biofeedback has been very useful in patients with migraine headaches. When an aura, a warning sign, occurs before migraine headache, patients are prompted to begin the exercise that relaxes them, maybe allowing them to prevent the headache. Physical agents can contribute directly to the patient's comfort. Examples of physical agents include applications of heat or cold, massage, and exercise. Additional physical interventions, such as immobilization or transcutaneous electrical nerve stimulation, TENS, are also available. Application of heat. The application of heat to sore muscles and joints is effective for pain relief. Heat works to increase circulation, induce muscle relaxation, and decrease inflammation when applied to a painful area. Heat can be applied using dry or moist packs or wraps, or in a bath or whirlpool. Heat is contraindicated in conditions that would be worsened by its use, such as in an area of trauma, because of the possibility of increased swelling caused by vasodilation. To prevent burns, heat should not be applied directly to the skin or over areas of decreased sensation. Application of cold. Cold can reduce swelling, bleeding, and pain when used to treat a new injury. It can also reduce the pain of an injection when applied prior to the injection, along with pressure above the injection site. Cold can be applied by a variety of methods, such as cold wraps and cold packs, as well as localized ice massage. Patients often choose heat over cold if they have the choice because cold can be uncomfortable. Cold may be better tolerated over a small area. Alternating heat and cold therapies is most effective if not contraindicated. Massage and exercise. Massage and exercise are used to stretch and regain muscle and tendon length and to relax muscles. Massage pressure can be superficial or deep and may involve vibration. It is important that massage is acceptable and not offensive to the patient. Immobilization is used after a variety of orthopedic procedures, as well as fractures and other injuries worsened by movement. Acupressure has also been shown to be beneficial for pain reduction. See evidence-based practice. Physical agents are readily available and inexpensive and often require little preparation or instruction. But always remember, it is important to use non-pharmacological treatments as an enhancement of appropriate drug treatments, not as a substitute. Evidence-based practice. Can acupressure, clinical question, can acupressure help relieve pain and reduce the need for pharmacological analgesics? Evidence. 15 small studies were reviewed to determine the effectiveness of using finger and hand pressure to stimulate acupoints and relieve pain. The studies demonstrated a reduction in menstrual, labor, low back, headache, and other types of pain in diverse populations. Implications for nursing practice. Acupressure can be efficiently conducted by healthcare professionals as an adjuvant therapy in general practice for pain relief. Nurses can be trained to perform acupressure. Nursing process for the patient experiencing pain. Data collection. This is on page 132. Accurate assessment of pain is essential to effective treatment. Without appropriate assessment, it is not possible to intervene in a way that meets the patient's needs. Because of regulatory requirements, most organizations require detailed pain assessments of patients at admission with any change in condition and at least every 3 months thereafter while in care. Nurses should verbally assess all patients under their care at least every 3 months, at least once per shift for pain and provide appropriate intervention as needed. The What's Up format introduced in Chapter 1 can help you perform a complete and effective assessment. Table 10.4. The following sections provide some additional key points for assessing pain and putting together more pieces of the pain puzzle. Accept the patient's report of pain. Pain is what the patient says it is, not what the HCP believes it is. When a member of the healthcare team distrusts the patient's report of pain, the patient can usually sense this. The patient may compensate by either underreporting pain or anxiously overreporting it. Patient may try to hide their pain for fear of being thought of as complainers or drug seekers. What's Up Guide for Pain Assessment. The W is for where's the pain? Be specific. Use a drawing of the body if needed. H, how does the pain feel? Is the pain shooting, burning, dull, sharp, aching? The A is for aggravating and alleviating factors. What makes the pain better? What makes it worse? T is for timing. When did the pain start? Is it intermittent, continuous? S is for severity. How bad is the pain on a scale of 0 to 10? Use a different tool such as the FACES pain scale revised, see figure 10.2, or pain ad scale, see figure 10.3 if needed. U is for useful other data. Are any other symptoms associated with the pain or pain treatment? Itching, nausea, sedation, constipation? How does the pain affect lifestyle? For example, inability to eat, sleep, work, or enjoy sex. P is for patient's perception. What is the patient's perception of what caused the pain? Is the patient experiencing suffering? Is the patient satisfied with pain control? Patient perspective, Terry. I have had chronic back pain for 10 years. It is very real, related to multiple herniated discs in my thoracic and lumbar spine, arthritis, and degenerative disc disease. Because I've been dealing with it for 10 years, I have adapted. I don't look like I'm in pain. Sometimes I limp or move around a lot to find a comfortable position, but I don't have that pained look on my face, and my blood pressure doesn't go up like some people. I have tried many, many medications over the years and have become quite educated in pain treatments. I have tried antidepressants and anti-seizure medications. Both are used for neuropathic pain. Ice, heat, transcutaneous electrical nerve stimulation, which is TENS, relaxation, physical therapy, more physical therapy, exercises, more exercises, massage therapy, steroid injection, and nerve blocks. I had relief once for about a month following some injections, and I kept thinking something was wrong. Wait, where's the pain? This doesn't feel right. Sometimes I would like a huge dose of morphine, but I know that opioids for chronic pain are a one-way street to dependence. I do have a prescription for hydrocodone slash acetaminophen, also Norco, that I take a couple of times a month when I feel desperate. I ration them because I'm afraid of them. My friend Joanne also has back pain, which started 20 years ago. When it started, she was writhing in pain. I am positive her blood pressure was sky high. She couldn't move because of muscle spasms. She was also diagnosed with a herniated disc, but she had surgery to fix it. She said the nerve pain relief was already evident in the recovery room. Of course, surgery causes pain, so opioids are needed for a short while. But once healing started for Joanna, no pain. She still has acute pain from time to time when she experiences muscle spasms and can't move easily for several days. She takes muscle relaxers and has to lay low until the spasms resolve. Sometimes Joanna looks at me and says, "You don't look like you're in pain." At first, this made me feel bad, like she's comparing her pain to mine. Then one day, I realized the difference. She experiences acute pain, and I have chronic pain. I've adapted. She is way more miserable than I am when she is in pain, but it is short lived. My pain is not as severe, but after 10 years, it has worn me down. When you are a nurse, please believe your patients when they say they are in pain, even if they don't look like they are. Maybe they've gotten used to it, but that doesn't mean they enjoy feeling pain. Do whatever you can to make them feel better. Obtain a pain history. Obtain information from the patient about the pain he or she is experiencing, as well as the pain treatments used in the past. Letting the patient describe the pain in his or her own words helps establish a trust relationship between you and the patient. This is also the time to discover the effects the pain is having on the patient's quality of life. Does the pain prevent the patient from eating, sleeping, or participating in work or family activities? Are there adverse effects, such as nausea and vomiting or constipation, that need to be addressed? Also, observe for emotional and/or spiritual distress. Ask the patient about how he or she has coped with pain previously and what treatments have been effective and ineffective in the past. In nonverbal or cognitively impaired patients, information may be obtained from family members and the medical record. A painful diagnosis, such as arthritis, typically is a predictor of pain. A thorough history is essential so you can individualize pain interventions to fit the patient's needs. Pain assessment tools. Various tools are available to assist with accurate and complete pain assessment. You should become familiar with the tools used in your clinical practice setting and use them consistently. It is of utmost importance that all healthcare personnel caring for a particular patient use the same pain rating scale, whether it is a numerical scale, for example, 0 to 10, such as a visual analog scale, or the FACES pain scale, revised, figure 10.3. There should also be consistent scales in place for nonverbal slash cognitively impaired patients, such as the Pain Assessment in Advanced Dementia scale. Whatever scale is used, it must be one that has been validated with research. The FACES pain scale revised was initially developed for use in children and has since been revised with FACES that are more realistic for adults. The pain ad scale was developed for patients with advanced dementia, but is an effective tool for patients with cognitive and communicative barriers. Longer questionnaires are useful in meeting regulatory requirements for the completion of comprehensive pain assessments. Figure 10.5. These scales often contain examples of verbal pain descriptors, something many patients have difficulty verbalizing. A scale should also be used to monitor the patient's level of sedation after opioid administration. Any unexpected increase in the patient's level of sedation should be reported promptly to the RN or HCP. Finally, keeping a pain diary helps the patient to document pain ratings, interventions, and responses, which can help with the treatment of pain. Perform a complete physical assessment. A thorough physical assessment is necessary to determine the effect of the pain and pain treatments on the body. It helps identify all of the pain sites and any medication side effects. It also helps prioritize the seemingly overwhelming task of helping the patient achieve acceptable pain relief and quality of life. As discussed previously, the patient with acute pain may exhibit signs such as grimacing and moaning, or elevated pulse and blood pressure. For patients with cognitive impairments, these indicators can be particularly important. However, these signs cannot be relied upon to prove that a patient is in pain. The only reliable source of pain assessment is the patient's self-report. Even patients with cognitive deficits can provide important information about pain. They can often answer simple yes or no questions regarding comfort and may demonstrate favorable changes in behavior, such as diminished calling out when pain is effectively controlled. Having accurate information regarding patient pain and activity levels before and after medications, particularly opioids, helps the HCP ensure that the medications are prescribed as needed. And this figure 10.2 shows the analog pain scale, with 0 being no pain, 2 is mild pain, 5 is moderate, 9 is severe, and 10 is the worst pain. Gerontological issues on page 134. Pain in older adults. Older adults frequently have unmet pain needs. Some believe that pain is an anticipated part of aging and may be hesitant to take strong medications such as opioids for pain. Non-steroidal anti-inflammatory drugs, NSAIDs, are often contraindicated for older adults due to medication interactions and gastrointestinal side effects. However, patients should be evaluated for medications on an individual basis. Patients in long-term care facilities, particularly patients with cognitive deficits, should have medications for pain scheduled around the clock to ensure regular administration and effective pain control. Consider isolation, restlessness, confusion, aggression, and changes in appetite as possible signs of pain. Pulling at dressings, tugging at intravenous sites, and calling out can also be signs of discomfort. Any change in the patient's usual behavior should be considered a possible sign of discomfort. Remember to take more time when assessing pain in older adults because they may need more time to process what you are asking. Consider using the pain assessment in advanced dementia scale, PAINAD, when assessing confused patients. You can anticipate pain and provide relief measures to prevent severe pain. A trial dose of pain medication may help to determine if the patient's behavior is because of pain. Nagging achiness in hands and feet is often noted as a reason for decreased activity, inability to sleep, and altered functional ability. A hand or foot massage using lotion and gentle massage strokes is often a relaxing comfort measure. Opioid analgesic doses may need to be decreased by 25 to 50% initially because they tend to work longer and stronger in the older patient. 10.3 shows the FACES pain scale revised with 0, 2, 4, 6, 8, and 10. Figure 10.4 shows the PAINAD scale, which is for assessing pain in advanced dementia. So the first thing you're going to look at is if they are breathing independent of vocalization. And if it seems normal, you give them a 0. If you're seeing occasional labored breathing and maybe a short period of hyperventilation, score them a 1. If the patient has noisy labored breathing or maybe a long period of hyperventilation and Cheyne-Stokes respirations, you're going to give them a 2. Looking at their negative vocalization, if there isn't any, you can give them a 0. If they have an occasional moan or groan or maybe a low level speech with a negative or disapproving quality, you can give them 1 point. And if there's been repeated troubled calling out, loud moaning or groaning or crying, give them a 2. Look at the facial expression. If they're smiling or inexpressive, you don't give them any points. If they seem to be sad, frightened, or if they frown, you can give them 1 point. But if there's actual facial grimacing, you're going to give them 2 points. Look at their body language. If they're relaxed, they don't need points. If they're tense or maybe there's some distressed pacing and fidgeting, you're going to give them a 1. But if they are rigid and their fists are clenched, maybe their knees are pulled up, or they're pulling or pushing away or striking out, then you're going to give them 2 points. The last area to look at is the consolability. So if they don't need to be consoled at all, you don't need to give them any points either. But if they are distracted or reassured by a voice or touch, you can give them 1 point. But if you are unable to console, distract, or reassure them, you give them 2 points. So what you end up with is a rating that is on a scale of 0 to 10. And this is really helpful for other types of patients that are not able to communicate their pain. Nursing, diagnosis, planning, and implementation on page 135. See nursing care plan for the patient in pain. Some additional principles to consider during planning and implementation follow. Set goals with patients and caregivers. Establish a pain control goal during the planning phase. Ask the patient to determine an acceptable level of pain if complete freedom from pain is not possible. Patients with cognitive deficits should also have pain goals established that include behavioral indicators. Education is important when helping patients and caregivers set realistic pain control goals. Although a pain goal of 0 is desirable, it may not be possible or safe. Conversely, a patient who chooses a pain goal of 6 may be unable to get out of bed and do daily or recovery activities. Patients should also identify activity goals. After surgery, goals may include the ability to ambulate and achieve restful sleep. For patients with chronic pain, the goals may be different. For example, a patient with terminal cancer may want to be able to eat dinner with her family in the evening. You can assist the patient in reaching that goal by teaching her to conserve energy during the day for the activity that is most important to her. Instructing both types of patients in optimal timing of pain medications and appropriate use of non-pharmacological treatments will also assist them in reaching their desired activity goals. Giving patients pain management options can provide autonomy and may help prevent feelings of helplessness and hopelessness. It is the nurse's responsibility to engage the patient and family in the pain management plan. Figure 10.5 is a pain assessment chart modified, and it shows 10 different sections that are completed by the patient. The name, the date, the date the pain started, the location of the pain, there's a drawing for that to be indicated, the description of the predominant pain in the patient's words, and then intensity on a scale, so 0, no pain, and 10, the most intense. And then 4 would be the duration of the pain and when it occurs. 5 would be the precipitating factors, and 6, the alleviating factors. 7, you can check off the accompanying symptoms. So if you have GI symptoms such as nausea, emesis, constipation, or anorexia, maybe you have CNS symptoms such as drowsiness, confusion, or hallucinations. possibly some psychosocial symptoms, regarding the mood. Maybe there's anger, anxiety, depression, or some relationship issues. 8, there might be other symptoms related to sleep, fatigue, activity, or even something else. And then 9 is where you would list the present medications and then the doses and times that were medicated during the last 48 hours. And then 10 is an area to include in the information on breakthrough pain. Figure 10.6 is the level of sedation scale, with S being normal, and then 1 is a normal asleep is S, and then 1 is awake and alert, 2 is occasionally drowsy, 3 is frequently drowsy, and 4 is unable to arouse. Understand that pain affects the whole family, and this is on page 137 of my book. It is important to include the whole family in the pain management plan. Understanding family dynamics helps in implementing an effective plan. Cultural influences are also important to consider. See Chapter 4 and Cultural Considerations. It is difficult for family members to see loved ones in pain or in heavily sedated states. Including them in planning helps them feel that they can help make the patient more comfortable and recognizes the important role they have in the patient's care. Nursing care plan for the patient in pain. Nursing diagnosis: pain, acute or chronic. Expected outcomes: pain will be at a level that is acceptable to the patient. The patient will be able to participate in activities that are important to him or her. Evaluation of outcomes: is pain at a level that is acceptable to the patient? Is the patient able to participate in activities that he or she has identified as important? Intervention: assess pain based on patient report. Use the What's Up format. The patient's pain is defined as what the patient says it is and when the patient says it is occurring. Does the patient verbalize his or her pain? Does the patient use verbal or nonverbal messages that imply trust in the nurse's belief of the pain report? Teach the patient to use a pain rating scale. Use the same scales consistently. A rating scale is the most reliable method for assessing pain severity. Does the patient understand to use the scale and use it to report pain? Does the patient or caregiver keep a pain diary documenting time of pain, interventions, and pre and post pain ratings? A diary can show patterns of pain and pain relief and help in planning care. Does diary reveal patterns that help with planning? Determine what is an acceptable pain level for the patient. Consider activities the patient should be able to perform. Only the patient can decide what pain level is acceptable. Is the patient's pain at an acceptable level? Can they perform necessary activities of daily living with minimal pain? Assess whether pain is nociceptive, neuropathic, or both. Nociceptive and neuropathic pain may present differently and may require different interventions. Has nociceptive versus neuropathic pain been identified? Are treatments appropriate? Assess need for and offer emotional, spiritual, and social support for the experience of pain and suffering. Pain, as well as disease processes, can be accompanied by feelings of powerlessness, distress, and isolation. Does patient appear emotional, angry, or withdrawn? Does patient have difficulty making decisions? Does patient have a support system? Is patient-nurse relationship therapeutic? Give analgesics before pain becomes severe. For persistent pain, give analgesics around the clock. Pain can be more difficult to relieve when it becomes severe. Is the analgesic schedule effective? Combine opioid and non-opioid analgesics as ordered. Balanced analgesia provides optimum pain relief with fewer side effects. Is the analgesic combination effective? Assess pain relief approximately 1 hour after administration of oral analgesics or 30 minutes after intravenous analgesics. If pain is not relieved, additional measures will be needed. Does patient report an acceptable level of relief? Observe for adverse effects of pain medication. Many pain medications will cause nausea and fatigue. Both tend to subside after a few days. Are adverse effects occurring? Can they be managed? Does medication regimen need to be adjusted? If opioids and or muscle relaxants are being used, assess for respiratory depression and level of sedation at regular intervals. Sedation and respiratory depression are risks if the patient is opioid naive or the dose is increased. Sedation always precedes respiratory depression. Is the patient's respiratory rate greater than 8 per minute or above the parameter ordered by the healthcare provider? What is the patient's level of consciousness? Institute measures to prevent constipation. 8 to 10 glasses of non-caffeinated fluid daily unless contraindicated, and exercise as tolerated. Opioid-induced constipation is a problem of gastrointestinal motility. Stimulant laxatives are most effective. Caffeine can exacerbate constipation. Is patient easily passing soft feces in the expected amount every 1 to 3 days? Teach patient to incorporate non-pharmacological pain relief interventions, such as using hot or cold packs and initiating relaxation techniques when taking medication. Non-pharmacological interventions can help the patient feel in control and may help reduce the perception of pain. Does patient use non-pharmacological interventions effectively? Determine whether the patient is taking pain medications appropriately, and if not, determine the reasons. Discuss how interventions may be modified. Pain medications must be taken appropriately to be effective. Is patient able to manage the pain control regimen? Does the patient have concerns about the medications? Are adjustments necessary? Recognize that pain is exhausting. Pain may keep the patient from sleeping well. This cycle of sleeplessness and pain must be interrupted to help the patient. Fatigue is a common problem for the patient with chronic pain and can complicate the treatment process. Although older adults do not require as much sleep as younger adults, all patients must get at least 6 to 7 hours of uninterrupted sleep to be relaxed enough to break the cycle. Controlled release opioids may help maintain pain relief throughout the night. If controlled release medications are not used, it may be necessary to wake a patient to administer pain medication so that the pain does not get out of control. The addition of a sedative or sleep aid may be needed to allow the patient to go to sleep. Aromatherapy, such as lavender, ensuring the patient is comfortable, and limiting caffeine intake after 1500 can increase productive sleep. Use a team approach to pain management. The interdisciplinary pain management team includes the patient and family, the licensed practical nurse, the RN, the HCP, therapists, spiritual advisors, social workers, and pharmacists. Communication among team members is essential. It is the important link that allows the team to be effective in creating a plan that works for the patient. As the nurse, you play a vital role in ensuring the effective communication among team members, always remembering that the patient is at the center of the team. Patient education. Patients, and in some instances, their family members must be informed about the medications they are taking for pain management. This allows them to take an active role in their care. Patients who are informed about the goals of pain management and who are confident that their providers believe them are more likely to report unrelieved pain so that they can receive prompt and effective treatment. Goals include a satisfactory comfort level with minimal side effects and complications of pain and its treatment, as well as a reduced period of recovery. Patients should be provided with information about a drug's effects, common adverse effects, frequency of the dose and duration of action, and potential drug-drug and drug-food interactions if indicated. There are many special considerations for medications, such as controlled release oral agent and transdermal patches. Care must be taken to include these considerations in the education plan for the patient taking these drugs at home. Drug-specific instructions are found in drug handbooks or databases. Education must be presented at a level that the patient can understand. Written information should be included when appropriate. Informed patients use their medications more effectively and safely. Evaluation. The final phase of the nursing process is evaluation. Once the plan of care has been implemented, evaluate whether the patient's goals have been met. What is the patient's pain rating? Has the patient's identified goal for an acceptable level of pain been met? How were the pain treatments tolerated? Was the patient able to participate in activities that he or she identified as important? The plan should be continuously updated based on the evaluation. Critical thinking. Mr. Sebastian is a 75-year-old man who has been diagnosed with lung cancer and is anxious about leaving the hospital to return home following surgery. The nursing assessment reveals the need for home health care for dressing changes and teaching about the medications he will need at home. While in the hospital, Mr. Sebastian has required 5 milligrams of intravenous morphine every 4 hours around the clock. Number one, the morphine is available in syringes pre-filled with morphine grains 1/6 per milliliter. How many milliliters should the nurse administer while Mr. Sebastian is in the hospital? And the answers are at the end of the chapter on page 140. And the math is shown there. So you're going to do 1.5 milligrams times 1 grain over 60 milligrams, and then 1 milliliter over 1/6 of a grain, which is going to come out to 0.5 milliliters. Number 2, what discharge instructions must be given to Mr. Sebastian and his wife before sending him home? Home instruction regarding around-the-clock administration of pain medication is indicated, as well as effects and side effects to report. He will also need to implement measures to prevent constipation. Number 3, how might his pain be managed at home to prevent unnecessary readmissions to the hospital? Number 3, MS Contin, a long-acting oral form of morphine may be an option for Mr. Sebastian, along with an immediate release preparation for breakthrough pain. Make sure to check an equinalgesic chart to be sure his oral dose is adequate. Also, information about what to do and whom to contact if pain becomes unmanageable is necessary to help prevent readmissions to the hospital. Home health hints. Emotional or spiritual distress and fear related to dependence on family caregivers may alter the patient's perception or report of pain. Some patients may feel pain more intensely because of the influence of fear, and others may underreport it if they are trying to protect family members. Pill boxes are useful to ease in administration of medications and for nurses to track usage. Medications should be locked up if there is a child or a teen in the home. A referral for palliative care may be appropriate for patients experiencing chronic pain. Okay, we have 11 review questions at the end of the chapter. And there's answers that were provided on the F.A. Davis website that are also in the back of the book, and I'm showing them on the left side of the screen. A patient is walking up and down the hall and visiting and laughing with other patients. When the nurse approaches, the patient reports a pain level of 6 on a scale of 0 to 10. Based on McCaffrey's definition of pain, which of the following assumptions by the nurse is most likely correct? 1, the patient is not really in pain, but just wants medication. 2, the patient is having pain at a level 6 on a scale of 0 to 10. 3, the patient is in minimal pain and should receive an oral analgesic instead of an injection. Or 4, the patient is in pain but does not need pain medication yet. And the answer is 2. It's whatever the patient says it is. The patient is having pain at a level of 6 on a scale of 0 to 10. Number 2, a patient with terminal cancer has been requiring 5 milligrams of intravenous morphine every 1 to 2 hours to control pain. Yet the patient is engrossed in a movie on television and appears to be in no pain. Which of the following explanations of this behavior is most likely correct? Is it 1, denial of pain is common in patients with cancer? 2, the cancer treatment is working and the pain is improving. 3, the patient is hiding the pain to finish watching the movie undisturbed. Or 4, distraction can be an effective treatment for pain when used with appropriate drug treatments. And the answer number 2 is 4. Distraction can be an effective treatment for pain when used with appropriate drug treatments. Number 3, what action should the nurse take when a patient with cancer pain develops tolerance to opioid analgesics. One, slowly wean the patient from opioids. Two, request a referral to an addiction specialist for the patient. Three, talk to the registered nurse or HCP about increasing the dose of analgesic. Or four, offer the pain non-opioid alternatives for pain control. And the answer is three, talk to the RN or HCP about increasing the dose to help with their pain. Tolerance is the need for more medication to achieve the same effect. There is no ceiling effect for opioids, so if the patient is still in pain, the dose may need to be increased. Number four, a patient has surgical site pain 24 hours after a total hip replacement. All of the following medications are ordered. Which would be the most appropriate choice for the patient at this time? Number one, ibuprofen or Motrin. Two, hydromorphone or Dilaudid. Three, acetaminophen or Tylenol. Or four, gabapentin or Neurontin. And the answer is two, hydromorphone or Dilaudid. Surgery would cause acute nociceptive pain, which would be most appropriately treated with an opioid, especially 24 hours after surgery. Number five, a patient is receiving duloxetine or Cymbalta for neuropathic pain related to diabetes. Which symptoms of neuropathic pain should the nurse assess? Would it be one, tingling shock-like pain, two, dull aching pain, three, deep cramping pain, or four, throbbing aching pain? And the answer is one, neuropathic pain is most commonly described as shooting, tingling, or shock-like. Number six, which of the following methods is the most reliable way to assess the severity of a patient's pain? One, ask the patient to describe the pain. Two, observe the patient for physical signs of pain such as moaning and grimacing. Three, ask the patient to rate his or her pain using a ballot assessment scale. Four, ask a family member to rate the patient's pain. And the answer is three, ask the patient to rate his or her pain using a ballot assessment scale. A ballot assessment scale is the best way to quantify pain. Number seven, a patient is hospitalized following a motor vehicle accident with multiple orthopedic injuries. The patient reports acute pain at an 8 on a 0 to 10 scale. An order is written for morphine 6 milligrams intravenously every 4 hours as needed, as well as non-opioid oral analgesic every 4 hours as needed. To reduce the risk of adverse effects and maintain an acceptable level of sedation and pain control, which of the following analgesic schedules will be most effective? One, offer the opioid every 4 hours. Two, tell the patient to call when pain becomes severe and then give the drugs immediately. Three, give both the intravenous opioid and the oral non-opioid every 4 hours around the clock. Or four, alternate the intravenous analgesic with the non-opioid oral analgesic as needed. And the answer is three, give both the intravenous opioid and the oral non-opioid every 4 hours around the clock as needed. Number eight, an 88-year-old patient is admitted with a broken hip after a fall. An order is written for meperidine 50 to 75 milligrams intramuscularly every 4 hours as needed for pain. Which of the following actions should the nurse take first? 1, give them meperidine every 4 hours around the clock. 2, offer the meperidine every 4 to 6 hours as needed. 3, administer non-steroidal anti-inflammatory drug with the meperidine for added pain relief. Or 4, discuss the order with the registered nurse or healthcare provider. And the answer is 4. Discuss the order with the registered nurse or healthcare provider because meperidine should be avoided in older adult patients. Number 9, a patient is started on gabapentin or Neurontin 300 milligrams by mouth 3 times daily for chronic low back pain related to lumbar disc herniation. Which instruction should the nurse provide? 1, take the medication at the first sign of any pain up to 3 times daily. 2, take 1 capsule every 8 hours continuously to keep the pain under control. 3, take the medication only when you need it to prevent becoming addicted. 4, take 1 capsule 3 times a day, then stop it when the pain is under control. And the answer is 2, take 1 capsule every 8 hours continuously to keep pain under control. Gabapentin must be taken continuously to be effective. Chronic neuropathic pain is not likely to go away, so treatment will be ongoing. Number 10, a nurse receives an order to administer 1 milliliter of sterile normal saline solution intramuscularly to a patient suspected of opioid abuse. Which response by the nurse is appropriate? 1, administer the saline and document the patient's response in the medical record. 2, inform the patient that the saline was ordered instead of an opioid. 3, discuss concerns about the order with the supervisor and healthcare provider. Or 4, administer an appropriate dose of opioid instead of the saline. And the answer is 3, discuss concerns about the order with the supervisor and healthcare provider. A placebo should not be administered except in research studies. The supervisor should be involved in educating the physician. Number 11, a nurse needs to administer morphine 10 milligrams intramuscularly. It is supplied as grains 1/4 per milliliter. How many milliliters should the nurse prepare for injection? And the answer is 0.7 milliliters. It's 10 divided by 60 times a quarter grain over 1 milliliter. And that's all for Chapter 10, Nursing Care of Patients in Pain.